Good day and welcome to today's CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home Management live Q&A session. Please note that this webinar is being recorded. All participants are in a listen-only mode, and if you would like to ask a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn this call over to Lisa Sullivan. Please go ahead.
Thank you. And next slide, please. Good afternoon, everyone. My name is Lisa Sullivan. Welcome to the live Q&A session associated with the CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home Management training series. The live Q&A sessions are dedicated entirely to interacting with participants, sharing comments, and taking questions, and are intended to supplement the online training topics and provide nursing home personnel with an opportunity to ask questions of the CMS and CDC as they navigate through the pandemic. Thank you for taking the time to be with us here today, and a special thanks goes out to our CDC colleagues for partnering with us on this important training series. The slides from today are available on the QIO program website, and the recording from today's event will also be posted there within a week, so please be on the lookout. Next slide, please. We want to take just a moment to discuss the CMS-CDC Nursing Home COVID-19 training series and the function contained within the website that will allow you to print or save certificates of participation after each live or self-paced video training in which you or a team member participate. There are two ways to register for the series. Next slide, please. You can register for the CMS-CDC Nursing Home COVID-19 training series from the website or after viewing an entire training video. You will only need to register once. A tutorial has been created for the process and will be updated as it evolves. Please use the link provided in the chat and in the presentation for an online tutorial which will be continually revised to reflect even the slightest change for the most recent instructions. Next slide, please. Registering for the series through the website can be done by visiting www.nursinghometrainings.org using the browser of your choice and clicking Register at the bottom right of the landing page, circled here in red for your reference. After clicking, the Register for the CMS-CDC Nursing Home COVID-19 Training Series screen appears. Next slide, please. Complete the form with your first name and last name. This will be the name that appears on your certificate and is also your username. Enter your business email address in the user email field and create a password of your choice in the user password field. Be sure to enter your city, county, state, zip code, name of organization or nursing home, address of organization or nursing home, and the CMS certification number or CCN for your facility. The CCN is required to receive attendance credit, so don't forget that piece. Click on the Register button on the bottom right corner, circled here for reference, and a registration confirmation will be emailed to you from the CMS-CDC Nursing Home COVID-19 training series. Next slide, please. You can also register for the training series after viewing the training of your choice contained on the QIO program website. Wait until you see the Thank You for Watching screen after the video ends, seen here on this slide. Please be patient. This could take up to 1 minute. When you see that screen, click on the Access Certificate button in blue and register for the CMS-CDC Nursing Home COVID-19 training series. Next slide, please. Complete the form the same as we discussed when accessing the training series registration form through the website. The CCN is required, to receive attendance credit. Click on the Register button on the bottom right corner, circled here for your reference, and registration confirmation will be emailed to you from the CMS-CDC training series. Next slide, please. After you have registered for the training series, you can check your progress and print or save certificates of participation. View any training and wait until you see the Thank You for Watching screen after the video ends. Remember to please be patient as this can take a minute or so. Then click on that Access Certificate button and a lesson screen appears. Next slide. Click the Print Certificate button and the Thank you for participating in the training screen appears. Next slide. On the Thank you for participating in CMS-CDC Nursing Home COVID-19 training screen, any live trainings attended or self-paced trainings completed will appear. Click on any of the blue links in the certificate column on the left to print a certificate. Right-click the certificate to save to your computer. Next slide. After you've registered, you can check your training progress and print or save certificates of participation at any time. Go to www.nursinghometrainings.org and select the Login button on the left, circled here for reference, and a login screen will appear. Next slide. Enter the username or email address you used to register for the training series. Then enter the password that you selected during registration. Click Login and you will be brought to the Thank you for participating in the CMS-CDC Nursing Home COVID-19 Training Series screen, which is seen here on the right. On this screen, any live trainings attended or self-paced trainings completely appear. Click any of the blue links in the certificate column on the left to print your certificate. Right-click the certificate to save to your computer. Hopefully, this brief tutorial will help you get started with the registration and certificate function included within the training series and QIO program website. Please be advised that the process is evolving and use the link provided on this slide and in the chat for up-to-date tutorials on that process. Next slide, please. It is now my very esteemed pleasure to introduce some of the featured colleagues on the call today to assist us with answering questions you may have. Today, we're fortunate to have the following CDC colleagues joining us: Dr. Namali Stone and Dr. Kara Jacobs-Slivka. Also, our fellow CMS SMEs and COREs, Angel Davis, Marianne Butcher, and myself, along with Nancy Allard. Along with one of our coworkers from the Division of Nursing Homes, and today, joining us, that is Megan Hayden. Next slide, please. In addition, we are joined today by our previous speaker, Dr. Stacie Levine, who presented on the September 17th session, Accepting New Patients During an Active Pandemic, Considerations for Both Transfers from Hospitals and Admissions from the Community. We received a few pre-call questions that we will speak to today. Thank you so much for your submissions. We would also like to encourage our audience to get involved in posing questions to address while live. Please enter your question in the Q&A box. Now, this is located at the bottom of your screen. We will address as many as time allows during this call. Next slide, please. And I would like to turn this over to Angel Davis.
Thank you, Lisa. So at this time, we would like to conduct an open discussion. And please remember, we will get to all the comments and questions that we have time to address during the live event. So our first question is for Megan Hayden with the Division of Nursing Homes within CMS. Are nursing homes required to track vendors, for example, hospice workers, 14 days after they visit the facility for contact tracing and for signs and symptoms of COVID?
Sure. Thanks, Angel. So per our regulations, nursing homes must have policies and procedures for reporting communicable diseases to public health officials and according to state and federal regulations. So nursing homes must have communication with a vendor regarding their vendor's employees who come on site and have contact with staff and or residents in order to follow reporting requirements and follow up testing as appropriate. For example, we would expect that a nursing home would communicate to a hospice about a resident who is confirmed to have COVID-19 and had potentially exposed the hospice's nurse. In another situation, if a hospice nurse had provided care to a resident and had potentially exposed the resident, we would expect the hospice to communicate to the nursing home about the potential exposure to the resident. So nursing homes must also have occupational health policies that identify who needs to be placed on work restrictions because of illnesses or exposures. A nursing home would need to determine if an exposure occurred for staff or residents and take appropriate actions such as work exclusions or transmission-based precautions and testing. Thank you.
Okay, thank you. This is Nancy. We have a question for Dr. Levine. For all new admissions, should you be wearing an N95 in long-term care facilities?
So for all new admissions in which we don't know their COVID-19 status, I essentially treat them as a PUI. We put them in their own rooms with the transmission-based precautions protocol, which if not N95s are available, we have the staff wear them along with the appropriate eyewear or shields, the gowns and the gloves. If an N95 is not available, then a surgical mask is an appropriate alternative.
Thank you, Dr. Levine. Our next question is for Dr. Stone. Can you explain what outbreak testing is and how it relates to the 14-day incubation window?
Hi, everyone. Yes, this is Namali Stone, and appreciate the opportunity to talk with you all. So a couple of things to remember. From the point in time when somebody may be exposed to SARS-CoV-2 virus, they can have a fairly prolonged window of incubation where they have become infected, but they're not yet manifesting any signs or symptoms of illness, and their viral, the presence of the virus may not actually be picked up on diagnostic testing right away. And so knowing that, we can have a group of people who were exposed, and we need to aggressively be looking over those first 14 days from that initial exposure, and what we define as a new outbreak that that warrants investigation, right, is a newly recognized staff person who is confirmed with COVID infection, or a resident who has been in the center for longer than 14 days from the time of their admission, and they, so we consider, and they are now diagnosed with a COVID-19 infection. And that exposure to a confirmed case prompts the beginning of outbreak testing. And from that initial recognized case, we recommend very frequent testing of all the residents and staff who are not already known to be COVID positive or recovering from COVID. Test them on a cadence between 3 to 7 days until we get 2 full weeks without detecting any new incident cases of COVID infection. So the reason we say to continue testing out until you have 14 days of no test has to do with, or 14 days of no new cases, has to do with the fact that we want to ensure we're looking aggressively for unrecognized infected individuals who may be harboring the SARS-CoV-2 virus until we get out of that incubation period. So hopefully that kind of explains for everyone why we define the testing frequency to go be until you get to 14 days with no new cases identified. Thanks.
Thank you, Dr. Stone. For the next question, I think this is for Dr. Levine. Are all new admissions required to be put in isolation for 14 days, even if they have a negative COVID test within 48 hours of admission?
The answer is yes. The reason being similar to what Dr. Stone had commented on, which is even if they were tested prior 2 days, there could have been exposure within that 48-hour window. And so you just don't know. And the best case scenario is to put them in isolation and treat them as someone who is still a COVID unknown status and quarantine them for the full 14 days until you safely believe that this person has not acquired COVID-19 in that short period of time.
Thank you, Dr. Levine. The next question is for Megan. Does the employee testing have to include staff that do not enter resident rooms?
So this question is referring to a memo that we released. It's number 2038NH, and that was in August as a result of the interim final rule that addresses testing of residents and facility staff. So in that memo, it does define what facility staff is, and that includes employees, consultants, contractors, volunteers, and caregivers who provide care and service to residents on behalf of the facility and students in the facility's nurse aid training programs or from affiliated academic institutions. This does include staff that do not enter resident rooms as they can transmit COVID in the facility, so for example, to other staff members. Thank you.
Thank you, Megan. This next question is for Dr. Stone. Can you speak to what the current best practice on resident staff testing, frequency of testing once COVID-19 is found positive in a long-term care skilled nursing facility?
So thanks. I think this is along the lines of the previous question I answered, just to reiterate that when COVID is first recognized, a new case is identified in a center, then we recommend fairly frequent repeat testing of individuals whose COVID status is unknown, and the cadence is between every 3 to 7 days. And I'm just going to share that as we have worked with centers and learned from their experiences doing this testing, we are learning that the more frequently those tests are performed, the more effective their ability to detect asymptomatic or pre-symptomatic residents or staff quickly and appropriately place them in precautions or furlough. So they reduce the exposure of other people in the center. So now that we are expanding testing capacity in a lot of centers and things like the point of care antigen testing platforms are available and relationships with laboratories are stronger and their capacity is better, so they're able to turn around results very quickly, ideally within 48 hours, the more frequent you're able to repeat those tests, the better chance you will have of quickly identifying and responding to new cases. And again, that serial testing continues until you go for 14 days without identifying any new infected individuals. Thanks.
Thank you, Dr. Stone. Our next question is for Dr. Jacob Swifka. This is regarding staff. Do we need to have separate staff care for those in isolation that are new admissions and not let them care for the existing residents?
Hi. So if you're able to dedicate staff, I mean, it's definitely ideal. Should anyone in that scenario become infected or develop infection, there's a more limited number of individuals that could possibly be exposed. CDC has specifically made recommendations about dedicating staff for COVID-19 care units. So where residents will go when they have confirmed COVID-19, they've tested positive. So that should definitely be your first priority in terms of dedicating staff. We haven't specifically come out and recommended that other areas should have dedicated staff. But again, if you are able to do this, if you're able to dedicate staff to units like an observation area where those new admissions are going for the first 14 days, then we would definitely not discourage you from doing something like that. Thanks.
Thank you. And our next question, I believe, is for Dr. Levine. The question is, can you cohort new admissions if they were admitted on the same day in a facility that has semi-private rooms?
The preference would be for them to have their individual rooms because, again, you don't know if they've been exposed or if the other person has been exposed. So even upon arrival on the same day, even if they're coming from the same place, there's still this question of whether or not the virus had been, if they've been exposed to that virus at some point during their transition. So my recommendation, if you can do this, if you have the ability to do this, is to put people in their private rooms so that they can quarantine until you feel more confident that they have not acquired COVID-19.
Thank you, Dr. Levine. Our next question is for Megan. So we just received word this morning that we have a positive case, a dietary worker. We received results this morning. Do we need to complete testing building-wide for residents if she is not a direct caregiver?
Sure, thank you. So this also goes to the memo that I referenced. It was released in August as well. And our memo does state that upon identification of a single new case of COVID-19 infection in any staff or residents, and again, this goes to for residents this would be for residents that would be a nursing home onset case and would be classified as an outbreak. All staff and residents should be tested. And all staff and residents that tested negative should be retested every 3 to 7 days until testing identifies no new cases of COVID-19 infection among staff or residents for a period of at least 14 days since the most recent positive result, and we have previously heard that. So your facility should initiate outbreak testing per our regulation. Thank you.
Thank you. This next question is for Dr. Levine. It was the question is to follow up on Dr. Levine's response to what POEs to wear for newly admitted residents to the nursing home. I agree with your response if the resident's COVID status is unknown, such as direct community admit. Is this your recommendation for residents admitted from a hospital, given the guidance stated that hospitals are prohibited from discharging a COVID-19 patient to any nursing home?
So the nursing home has to be able to accept the patient, largely because the nursing home has to be able to manage transmission-based precautions. If the nursing facility is unable to follow the guidelines, then they need to work with their local health department to identify where the issues are. Maybe they don't have enough PPE or they're unable to adequately cohort the residents. Ideally, in thinking geographically about your building, whether it's a ranch-style building where you have multiple wings or you have a multi-level building, to think about, I almost would say like red, yellow, and green. So the red being your known COVID positive cases, yellow being your PUIs or your unknown cases that you're putting in quarantine, and then your green being what we call the pure as a driven snow, the people that you are confident don't have COVID-19 because they've gone through the full 14-day quarantine. and are not having any symptoms. And so if there's a way that you could geographically locate your building and structure it in that manner, then you can and manage the transmission-based precautions, then you can safely accept patients from any status out of those 3 different levels.
Thank you, Dr. Levine. So our next question is for Dr. Jacob Slifka, and this is regarding quarantine and cohorting. When residents go out to a physician appointment, we are placing them in quarantine times 14 days upon return, as they may have been exposed to someone with COVID while out of the facility. We also quarantine residents that go home for a leave of absence. This uses up quite a bit of our beds that could be used for new admissions. Is this the correct process?
Thanks. So as of right now, CDC has recommended that depending on the prevalence of COVID in your community, that newly admitted or readmitted residents, so people coming, new admissions to your facility, go into that 14-day observation quarantine using all the recommended COVID PPE as we've been describing on the call. CDC hasn't made the recommendation across the board that anyone leaving the facility, like going to the emergency department, dialysis, or another outpatient visit, would also go into that 14-day quarantine. In any of the examples, though, if a resident is leaving, they should be, if they're able to tolerate doing so, wearing a mask when they're out of their room, including away from the building. But you bring up what's definitely a gray area right now for residents who are leaving the facility. And it can be a little challenging to estimate their potential risk of exposure while they're gone. So if you're in an area, for example, where you have a lot of COVID activity, or you have specific concerns for exposure when they are leaving the building, then it wouldn't be wrong to use that information to guide your actions and how you manage that individual when they come back into the building. And of course, if you ever suspect COVID, you definitely want to put that person into transmission-based precautions and perform testing if you suspect that they have COVID. Specifically for leave of absence, I think that's an interesting point. I mean, I think it's a similar situation where you are going to have to think about the risk of potential exposure for that resident, kind of, depending on COVID activity in the community, family and friends that the resident may come into contact with, precautionary measures that were taken or not during that leave, which you may or may not be able to determine, and then how long that resident is away. And then one other thing I will say is that I think it's important, depending on your location, to be aware, be familiar of any local or state policies, because there are some states that specifically have some additional guidance on this, and have specifically either are asking nursing homes to do a risk assessment for those residents and help use that information to guide whether you would put them into quarantine for 14 days. Some have said to have made decisions to do this or not to do this. So it is a challenging question. For sure, if it's a new admission, you put them into the 14 days of quarantine, but otherwise you're going to have to make an assessment. Thanks.
Thank you, Dr. Slifka. The next question is for Dr. Stone. With point-of-care testing, specifically the antigen testing, should there be a follow-up with a molecular assay test if the point-of-care test shows positive?
Hi, thanks for that question. It is somewhat dependent on the circumstance by which you're doing the testing. So what I mean by that, if I am performing the test on a resident or staff member who has symptoms and signs that are concerning for SARS-CoV-2 infection, and I get a positive antigen test for that individual, I'm going to trust that positive test and handle that individual as though they have COVID-19 infection, and place them in appropriate precautions. And we don't currently recommend that you do any confirmatory or subsequent testing using a molecular test like a PCR. The time when we, and that is true also in handling specimens taken among asymptomatic residents and staff during an outbreak investigation, where we know that there's been a case exposure and we are using the point of care test to quickly identify individuals who may be asymptomatic or pre-symptomatic with infection, and acting on those results. The one circumstance where CDC does recommend confirmatory testing with a molecular test for a positive point of care antigen test is in the circumstance where I'm doing testing as part of screening staff on a cadence based on the county prevalence of COVID positivity in my community. And when a center is in a low prevalence area, COVID circulation is low, and your suspicion of COVID is low because the person is asymptomatic, they have no recognized exposure. In that circumstance, if you get a point of care antigen test that's positive, we recommend doing a molecular test like a PCR test to verify that, because there is a small number of these tests that may be false positives when you're using the tests a lot in an area where there really isn't a lot of virus circulating. And I will put a link in the chat box for everyone to see our guidance, which has an algorithm that you can download as a PDF and kind of walks you through these different situations. Thanks.
Thank you, Dr. Stone. The next question is for Megan. How often should positive facilities test on a routine basis versus buildings who do not have positives and are testing on a routine basis? Is it weekly or biweekly?
Okay, sure, thanks. So this again goes back to our testing memo that we released based off of our regulations. And so you have to determine whether the facility is a positive facility related to an outbreak, or whether it's admitting residents from, say, a hospital that are COVID positive and it's not nursing home onset. So again, if it's a facility that's positive because they have an outbreak, then of course they need to test right away. All staff and residents who have not tested positive in the last 3 months, unless of course they're symptomatic and another cause cannot be identified. Again, as I've stated before, they would have to continue testing all the staff and residents that tested negative every 3 to 7 days until the testing identifies no new cases of COVID infection for a period of at least 14 days since the most recent positive result. Now, if the facility is not experiencing an outbreak and these positives are due to admission of COVID cases, and therefore they're not nursing home onset, then the routine testing intervals for staff vary by the community COVID-19 activity level, the prevalence that we were just talking about. So facilities should use their county positivity rate as a trigger for staff testing frequency, and reports of the county level positivity are available on data.cms.gov website. So testing once a week is noted for facilities in a community with medium activity. So again, that positivity is 5 to 10%, and twice a week for those with high activity, so over 10% positivity. So again, it depends on the prevalence, and it depends on what is occurring in your facility as well. Thank you.
Okay, thank you. This question is for Dr. Levine. When using an N95 for new admissions, is it okay to place each one in a bag and hang the bag on the wall outside the door above the isolation cart with the staff's name for reuse?
Yeah, I have seen people do that. I mean, if you're in an area where you have a shortage of PPE, the CDC does have guidelines in terms of extended wear of equipment, and I'll certainly let them add on to this conversation. But I have seen people figuring out ways that they can extend the wear of their N95s, because we know that they are difficult to get in some regions of the country.
Okay, thank you, Dr. Levine. The next question is for Dr. Jacobs-Liska. Is staff required to wear full PPE, gown, N95 mask, and face shield with residents that are in 14-day quarantine, even if they are discharged from a facility with a negative COVID test?
Yes, yes. So essentially they are, and I think this is a similar question with that has come up on this call and some other calls before, but I think there's obviously some confusion, and I think we want to make sure that everyone fully understands about what recommended or what practices are recommended during that first 14 days. And so we do recommend that full PPE is worn, even if they have had a negative test. Our guidance is that anyone who has suspected or confirmed COVID wears the gown, gloves, eye protection, N95, respirator, or face mask if a respirator is not available. And similar as was said previously on the call, we want you to think about these residents in observation in that 14-day quarantine similarly, and approach PPE use similarly, as if those newly admitted residents might have COVID. You're watching them because you think that they may have been exposed, and it's possible they could develop infection. And so just a reminder that even if they have a negative test from the prior facility that they were at, that negative test is still just that it's negative at that point in time, but they may have still had an exposure in the few days preceding that, or even up to the point of their discharge. And so they still have potentially up to a 14-day period of time once they're admitted to your facility, in which if they were exposed, they could go on to develop infection. So essentially, yes, they should be wearing full PPE, gown, N95, respirator or face mask if respirator is not available, gloves, and eye protection, which could be goggles or face shield. Thanks.
Thank you. This next question is for Dr. Stone. What happens if a center is located in a county with high COVID positivity and is supposed to test twice a week, but lab supplies are limited?
Hi, thanks. I appreciate that question. I think it's incredibly important and very pragmatic, because we know that there are still challenges with replenishing supplies, and so centers have to be sort of judicious about their inventory. And so we recommend that a center maintains a supply of tests to be able to react to symptomatic residents or healthcare personnel, and prioritize individuals with symptoms for the use of those tests, and ideally have some capacity to be able to do some expanded testing of other individuals that may be exposed in the circumstance that that symptomatic person is confirmed to have COVID-19. I know that this can be a difficult thing to determine because the extent of an exposure is hard to predict. We recommend, of course, that in the entire center, residents and staff are all tested if you have a new case confirmed. But I think one of the important parts of addressing a supply concern is doing some outreach to your health department to make them aware that you're in a circumstance where you're concerned about your test inventory, and I would get some guidance from them as well, because if you're in a community where the prevalence is high enough that you're meant to be doing twice a week testing, we know that you're in a community where there's a very high risk of SARS-CoV-2 introduction to the center, and so you do need to have a pathway for an outbreak response if your own supply may not be enough. So you want to be reaching out to your health department and also exploring other laboratory vendors that may be able to help you in the case of an outbreak response, so you're not, so that you have a plan in case this occurs. But I appreciate the question. I know it's a very hard thing to determine. Thanks.
Thanks, Dr. Stone. The next question is from Megan, and this is regarding the August 26, 2020 QSO Memo 2038NH. Page 4 states that for an individual who tests positive for COVID-19, repeat testing is not recommended. A symptom-based strategy is intended to replace the need for repeated testing. Facilities should follow the CDC guidance for discontinuing transmission-based precautions. This seems to be a contradiction. Would you please clarify?
Sure. So what this memo is stating in that instance is that it's discussing what the current recommendations are for discontinuing transmission-based precautions, and that repeat testing is generally no longer recommended, again, because, again, you can continue to test positive for a period of time, therefore moving towards the symptom-based and time period-based strategy for discontinuing the transmission-based precautions. And just to note that the facility, is going to have to determine, again, if the resident or the employee, the health status, again, how serious their illness was in determining how long to maintain transmission-based precautions. And again, that time period. Also, just to take a look at CDC's criteria for returning to work, again, for employees, is just something else I would mention. Again, it's really getting at moving away from that test-based strategy for discontinuation and moving towards that symptom and time-based strategy. Thank you.
Thank you. This next question is for Dr. Stone. If a rapid antigen test is followed by a PCR confirmatory test and they have different results, which test should we be reporting?
Yes, hi. This is a very fair question, and it's also a little complicated because there are different entities to whom you all are being asked to report. At this time, I don't believe we have put guidance officially on the NHSN website around discordant results. However, I believe, and again, I would want to confirm this with my colleagues, that if an individual is test positive and the follow-up PCR test is negative and the belief is this is a false positive antigen, I believe NHSN would recommend not identifying and reporting that staff person as a case. There may be, I'm sure there are circumstances where this is less clear-cut. And so there are situations where we would, especially when it comes to notifying your health departments, want you to call your local health department in your state and talk through the circumstance of the testing and the results and which directionality the discordance is occurring, because we want you to have all the support you can to make the best interpretation and implement the best response to the results that you're getting. Thanks.
Thank you, Dr. Stone. The next question is for Dr. Jacobs-Lipka. Can we please clarify isolation and quarantine? We seem to be using this terminology interchangeably. My understanding was isolation was 10 days and quarantine/observation 14 days.
Yeah, I definitely appreciate this question being raised, because sometimes the terms are used interchangeably, although regarding infections and infection prevention, they do mean slightly different things, but it's a little confusing. I think most simply when we talk about isolating someone, I mean, although isolation can mean separation, when we talk about isolating someone, we're talking about someone who's sick or infected, and when we talk about quarantine, we're talking about someone who we think may have been exposed, and we're worried might go on to develop an infection. And since a definite exposure isn't always known, we're often talking about, it's possible they could have had an exposure, or there's a risk of exposure. Those are folks that we group into that quarantine. So for both of these, though, you're really keeping that individual, you're separating them. So you are technically isolating them, but you're separating them away from others, and then you're using things like PPE to prevent the pathogen. In this case, we're talking about SARS-CoV-2 causing COVID-19 from spreading. So you're correct in that we recommend 14 days of quarantine, or we've been calling it observation. And the reason we do that is that the incubation period, that period of time after someone is exposed to the virus that causes COVID-19, is between 2 to 14 days. It's up to 14 days in which they could go on to develop infection. So we quarantine them or observe them for 14 days, keeping them away from others, and using precautions to keep ourselves safe when we're providing care for them, because it's possible they could go on to develop infection. Where when we talk about the isolation period, or that length of time that we recommend the use of transmission-based precautions, so again, the similar PPE and room restriction, it is at least 10 days, but it may differ a little bit depending on symptoms, severity of illness, whether or not you're severely immunocompromised. So I would say at least a 10-day minimum, provided symptoms are improving, no fevers for 24 hours, and that it's been a mild to moderate illness without any evidence of severely immunocompromised status. So they are slightly different things. They do have slightly different meanings, quarantine and isolation. You do hear them often mixed kind of back and forth, but we're talking about that incubation period, that period where we're watching someone to see if they go on to develop infection after an exposure, and that's in that quarantine period, versus that isolation period where we know that they have the infection and we are trying to keep them separated from others so that that infection or that pathogen is not spread. Thanks.
Thank you. This next question is for Dr. Stone. It was a follow-up question concerning the testing twice a week in COVID, high COVID positivity areas. They wanted to know, is the testing frequency based on positivity in the county mandatory or only a guidance?
Hi, so this is Namali. I actually think I want to see if my colleague Megan would like to speak to this, because I think it's getting into the testing requirements and regulatory expectations. Megan, do you?
Yeah, I'm on the line, so thanks. So again, first of all, you know, the memo 2038 NH, which again seems to be what I've been talking about each time I've been answering a question this time. So the reg does talk about, and I do apologize because I'm federal and, you know, we get to talk about regs and it's probably pretty boring for you guys to listen to this, but it talks about conducting testing based on parameters set forth by the secretary, including but not limited to testing frequency. So the regulation does state that, you know, again, CMS gets to stipulate the frequency of testing. And we go on to talk about that down below in the memo, the testing frequency. There is a table, it's table 2, that goes into the prevalence. Now, there's some caveats to that testing interval, okay? And so if you look at this table closely, you'll see a couple of things. You know, number one, it is required, but the caveats meaning that the point of care testing, you know, that can be used can have, or the testing can have a, you know, kind of a rapid turnaround where you can take action. If this turnaround time cannot be met due to testing supply shortages, limited access, or inability of laboratories to process the test, even if you're having to, you know, send them out and they're not able to process them within 48 hours. So the facility would then need to document its efforts, right, in order to meet the requirements that are set and to obtain those, you know, quick turnaround results. Okay, so they also need to try to work with their local health department, state health department, in order to meet these requirements. So I think to state that it is required if there's something occurring that is preventing the facility in order, you know, from being able to meet these requirements, it needs to be documented. Those efforts need to be taken to meet those requirements. So hopefully that answers that question. Thank you.
Thank you, Megan. And the next question is for Dr. Stone. Patients and staff who test positive for COVID, are they required to be tested after 3 months from the day they turn positive?
Yeah, thanks, Angel. I'm so glad that someone asked this question. The answer is no. That is not a recommendation as far as, you know, use of testing in the evaluation of somebody who is COVID recovered. I think you've heard Megan and a couple of us say that we are no longer recommending testing in the first 90 days following somebody's COVID infection and recovery, because we know that there's a lot of potential for continuous detection of virus that does not reflect reinfection or transmissible or sort of contagious virus to others. We do not ask for any kind of, I guess, confirmatory testing at all once somebody's out of that 90-day window. where the circumstance may be that somebody who is recovered and past the 90-day window would be eligible for testing again is if the testing is being done in response to a new case as part of an outbreak investigation, or if this is a staff person and they are now back in the cycle for the routine screening of staff that is part of trying to keep COVID, unrecognized COVID from coming into the building through, regular screening of staff based on the prevalence of COVID in the community. The only other time when we would recommend testing an individual who is recovered from COVID is if they develop new signs or symptoms that are concerning for COVID infection and there's no other identifiable cause. And that testing should happen anytime after that recovery period, even if it's less than 90 days from when their first infection occurred. So those are the times when you might test somebody who has recovered from COVID. Thanks.
Thank you, Dr. Stone. Next slide, please. So please join us for the next live Q&A session on October 8th from 4 to 5 p.m. Eastern Time. Registration is required, and we will put the registration link in the chat for your reference. Next slide, please. So thanks again for your participation in today's call. We hope you found some value in the topics discussed. Please take a moment to complete the survey from today's event. We use this information that you share to improve future sessions. Please have a wonderful day. Thank you.